three of these components are what contribute to an increase in intracranial pressure. So the brain tissue, so there are examples of that would be if there's swelling in the brain tissue, that can cause increased pressure in the inside the cranium, inside your head. Blood, if there's an increased amount of blood, so if there's a hemorrhage going on, and then if there's an increase or change in the cerebrospinal fluid. So those three things, the brain tissue, blood, and the cerebrospinal fluid, because we know that the skull doesn't give, right? So as a bone, there, you know, if the brain is swelling, it can only swell so much until there's gonna be extreme amount of pressure on it because the skull is not gonna give. So the, we know that if there's, like I just said, if there's swelling or increase in the brain tissue, the others try to decrease to maintain that equilibrium. So maybe the body tries to compensate by draining more of the cerebrospinal fluid, or you may see changes in the vital signs and things like that in order to try and compensate for these changes. But if there is not an intervention in a timely manner, the body's not able to compensate for it, then cerebral herniation syndrome. So herniation of the brain can actually occur. And so the actual it talks about vasogenic cytotoxic and that other really big word there. But the thing with the herniation syndrome, so they're going to be kind of classified, what it says in your book there, as far as the region of the tissue. But the later symptoms and clinical manifestations you're going to see in the client are going to be identified in the Cushing's triad. And so that's where the client is going to show an increase in their systolic blood pressure. There's going to be a decrease in their diastolic blood pressure, which is going to lead to a widening pulse pressure. And that's going to lead to bradycardia and then irregular respiratory patterns. So that's the Cushing's triad, those three things. So we're seeing those changes in the blood pressure, you're seeing the changes in the heart rate, and then the irregular respiratory pattern. Another late symptom that you also see mentioned there is where you see a unilateral fixed and dilated pupil. So that's going to be a later symptom. So what we're going to focus on is trying to identify what are the very early signs of increase in the intracranial pressure. What nursing interventions can we do in order to prevent it from progressing to a possible herniation syndrome or Cushing's triad or that unilateral fixed and dilated pupil. So that's kind of where we're going to be talking more about that. But the herniation actually occurs because there's so much pressure built, it builds up, and then it actually, we know that there at the base of the skull, that's where the opening is, where the spinal column actually comes up and joins. And so a herniation occurs, and that actually puts a whole lot of pressure on that particular area of the brain, and then that leads to, well, ultimately death if herniation syndrome occurs, because that's going to impact the part of the brain that controls your blood pressure, your respiratory rate, your temperature. All of those things will be completely out of control by putting too much pressure on that brain stem itself. So there are a couple of tables. Table 39.1 talks about the different cerebral herniation syndromes, identifies the clinical manifestations, which you're going to see common in all of those, coma. So coma and then ultimately death if there's not a way to reverse it that way. Table 39.2 talks about some of the cerebral edema. Table 39.3 is going to differentiate between the fact of whether we just have increased intracranial pressure or whether we have a true cerebral herniation has actually occurred. And then table 39.4, we're going to talk about that in more detail too, those different types of monitoring devices. But I just wanted to make a note of those. So when we are monitoring intracranial pressure, first of all, we need to be aware of what is the normal levels. Identified in your book, it's on page 865, normal ICP is 0 to 15. And it also talks about too, like what approach do we use in order to treat the increase in intracranial pressure. It says that if the ICP begins going over 20, we do have to implement interventions to decrease the pressure. In the ATI book, I referenced the pediatrics. That is on your outline, but chapter 13 and chapter 14 in the ATI pediatric book is where it talks about seizures and head injuries. And it does say there that if the intracranial pressure in a pediatric goes over 15, we have to intervene. So for an adult over 20, a child over 15.
Say it one more time.
Over 15, intracranial pressure greater than 15 in a child, interventions are necessary. And then your book says greater than 20 for an adult, interventions are necessary.
So it's 17-year-old over 20.
Yes, yes. Because that's gonna be more of the, they're fully developed, you know what I'm saying, their brain's gonna be fully developed by that point. And actually it does say a stepwise approach is gonna be initiated at 15. So. But we know the normal value is from 0 to 15, so we are gonna have to be taking measures of, especially if they have some type of injury, and we have the monitoring in place, and we're identifying that it's continuing to rise, we've got to be aware of what we need to do for those things.
You said chapter 13 and 14 and 15.
Yes, in the ATI pediatric book, that's correct. Yes, okay, and also on page 865, you see a little calculation there where you can determine what is the actual cerebral perfusion pressure, and that's CPP is the abbreviation for that. The normal, it says it's generally maintained above 60 millimeters mercury, so the normal is 60 to 100. And when it falls too low, the brain's not perfused adequately. The brain's not perfused adequately, we know that. Death can occur because it's not getting the blood flow, it's not getting the oxygen, it's not getting the nutrients that it needs to survive. So you calculate that by, remember we talked about the map just a couple of weeks ago, the mean arterial pressure. That tells us how well the blood pressure that we calculated is actually perfusing the body. So we use the mean arterial pressure, and then we subtract the intracranial pressure reading that we have, and that gives us the cerebral perfusion pressure.
And it's called the cerebral what?
Perfusion pressure.
Perfusion pressure, okay, thank you.
That's on page 865. So that measures the cerebral blood flow, and we want it to be above 60 is our goal. So you can see if you've got an issue where the intracranial pressure is rising, we know that that can affect the blood pressure. So if the blood pressure is going down and our mean arterial pressure is going down, and then we have an increase in intracranial pressure, so if our map's down to 65 and then we've got an ICP of 15, that's gonna put us at a 50 cerebral perfusion pressure, and that's too low. So you can see how those link up, how they connect, and how one is gonna contribute to the other. But this would require us to have some type of intracranial pressure monitoring device in place for us to be able to know exactly what that ICP is. So this would absolutely be in place in a client, maybe they had a traumatic brain injury, maybe they've had a hemorrhagic stroke, or, a car wreck, or a gunshot wound that affected the head. All of these different factors could play into the reasoning why they may have intracranial pressure monitoring in place. And so that's where table, on page 866, table 39.4, tells us the three main different devices that you will see. So, the subarachnoid bolt, the intraparenchymal monitor, or the intraventricular catheter. So all three of those, you can kind of see them. It is identified what are the advantages of each one of them, what are the disadvantages of each one. So the first one we're gonna talk a little bit more about is the subarachnoid bolt. And there on that table, it tells you that we've got a bolt or a screw connected to a fluid-filled transducer system. You can see an example of kind of what this transducer system and the drainage device and all of that on page 867 can kind of show you a visual aid of what may be on that IV pole right there at the client's bedside. So it is one of the subarachnoid bolts, one of the oldest types of measurement, an older method of measuring it. And they use that screw, insert it through a hole that they drill in the skull. But there are risks of the bolt actually being occluded with what if it's a blood clot, or what if it's some type of thickness of the fluid or something like that. There's a risk of it being occluded and then it not draining and then it not giving you accurate information when you're trying to measure the intracranial pressure. The intraparenchymal monitors, they're actually a little further in. They go through the dura, into the white matter, and actually goes into one of the frontal lobes. But the problem with this one, it can give you the ICP reading, but you'll see there in your book, the disadvantage, inability to drain the cerebrospinal fluid. So we've got a very invasive device. It can give us a pressure reading, but it can't drain. So that's a disadvantage of that. Subarachnoid bolt, same thing, inability to drain. So really, if you're looking at the three, you're gonna get the best readings and the best opportunity to kind of maintain some type of control of the amount of CSF fluid with the intraventricular catheter, because it can actually monitor the ICP and also drain the cerebrospinal fluid if there's an excess amount. So the IVC, intraventricular catheter, is going to be the one most commonly seen. You may hear it also called a ventriculostomy, but it is going to be considered more of the gold standard for ICP measurement. And you can also see with the ventriculostomy, that is the figure 39.4. On page 867, and you see there that there is a collection bag, there's a collection chamber, so they can actually turn the little stopcock, collect the amount of CSF in that collection chamber, so that way they can monitor very, very closely. So just like with any other type of drainage device that your client may have, if they have a ventriculostomy in place, that's gonna be an additional one of those output things. You would measure it just like you would a chest tube, or just like you would an NG tube or a JP drain. You want to be sure that you are accurately and routinely measuring the exact amount of cerebrospinal fluid that is being drained. So some of the complications, we know that all of these, they're important for us to, if we've got a client that needs this, we've got some kind of injury, it's important for us to be able to measure the intracranial pressure, but it's also going to come with risk and potential complications. So infection, we know we have kind of a direct line there into the brain that we need to be sure that everything is especially with the insertion of it that is done with the sterile technique, and all of the precautions are in place to protect that. Over drainage could be another complication, so if there is a significant amount, and there could be an excessive amount of drainage. So that's where you'll notice that there are stopcocks in the system, but it may be that if there is an excess amount, it could be draining excessively. So that's gonna be an issue that's gonna have to be monitored for. The risk of the introduction of air into that ventricular system, because this tubing, this probe is going right into the ventricle of the brain. So you wanna be sure that that proper leveling is gonna be maintained. So just like we talked about with those invasive hemodynamic monitoring devices with the transducer, again, there would be it would be an important nursing intervention for this to be maintained at the proper alignment with the client to prevent some of these complications. The book does mention that one of the potential complications of over drainage is the risk of a client developing a subdural hematoma. And so that's where you've got blood collecting in the subdural space, and so that could be a major risk in this situation. Yes?
I don't get this, cause like, the only time I open drainage, we gotta talk about a whole bunch of drainage in the collection tank.
Yes.
So how you get this up here, you tell me drainage in?
So it could put too much stress on the brain probably with the amount of drainage. And think about, like even when you've got a client that has, the ascites. If they drain the fluid too quickly, if they drain too much, they can have complications like disequilibrium type syndrome. Think about that with dialysis. So same sort of thing. It can affect them in different ways, but just too much drainage in too quick of a period of time, too much stress on what's surrounding that area can cause those other problems. So now we need to think about, we've got this client, we've got too much cerebrospinal fluid or too much blood, we've got issues with the increase in their intracranial pressure, and so what are some things that we are gonna do as far as management and treatment? So, obviously, our main treatment is gonna focus on whatever is increasing all the pressure, we're gonna focus on trying to decrease it. So if it's excess blood, excess, water, blood, CSF, so putting these drainage devices in place to decrease the amount of CSF. If it was some type of injury or something that caused the blood, they may need to go to surgery and have surgical repair. Sometimes with some of those surgeries, they'll actually create like a little window and remove part of the skull in order to be able to allow some of the swelling of the brain. That can help with decreasing some of the pressure there. So those could potentially be some of the treatments that may be used. Obviously, some of the diagnostics use CT, MRI, those types of things. Medications may be used in order to increase the blood osmolarity. Mannitol is one of the very specific medications, and it does talk about that in your book. And that's gonna be over on page 872, it's gonna talk about mannitol. So, with these clients, the use of mannitol, it acts sort of in a way of a diuretic type medication, but it's not gonna, Lasix and spironolactone, things like that aren't gonna cross that blood-brain barrier. So mannitol would be one. Ideally, it's gonna cross the blood-brain barrier, therefore, it's gonna help with removing an excess amount of fluid in the skull. So within that area around the brain, it's gonna help with decreasing the blood or pulling water from that interstitial space. So what it's gonna do is it's gonna pull that extra fluid and get it out of where it doesn't need to be and put it into the vascular space, so then the body can actually use it, excrete it, or whatever is needed in it to decrease the amount.
Put it back to the back.
Vasculars. So get it into the vascular space. So when the mannitol is used, you also need to account for dehydration. And it talks about that on page 873 in your book. It says, in order to compensate for the systemic dehydration and hypovolemia that occur, IV fluid should be administered to replace the losses. So it's gonna be doing a lot of pulling the fluid. And so you gotta think about the systemic dehydration. Also, right there on page 873, it does talk about using a high concentration of sodium chloride. And what that does is that helps cause a fluid shift. But it can be used in clients that maybe are more unstable, and so they're not stable enough to manage the amount of fluid shift that mannitol is gonna cause. But they could use the high concentration of sodium chloride, and it would be more of a gentle shift than the mannitol would bring about. Does that make sense? So you think about it, mannitol is gonna help with getting the excess blood, water, CSF back into the vascular space. High concentration sodium chloride can also do the same thing, and it can be done in a more of a gentle manner. So if you've got a client that's gonna be sensitive to it, and they have an increased intracranial pressure, then they may be a better candidate for the high concentration sodium chloride than the mannitol. So either one of those. The mannitol, yes. Yes. So the mannitol could cause too dramatic of a fluid shift. The high concentration sodium chloride wouldn't cause as dramatic, okay?
How would we differentiate?
The client condition, yeah. So if they're gonna be more sensitive, especially probably if they have real unstable vital signs, they may be a better candidate for the high concentration sodium chloride than the mannitol.
Okay.
Yeah. Does that make sense? So
So-
you're gonna need to have some information about the client to know. But specifically what the book says is that they are sensitive to fluid shifts. So probably if the change in their fluid status causes a significant drop in their blood pressure, and here we are trying to keep the brain perfused, then we don't need to cause a significant shift. So we're gonna go with the high concentration sodium
So-
chloride.
Unstable vital signs,
Yes.
sodium chloride,
Yes.
stable mannitol.
Yes, yeah, so if they're able to handle that, the mannitol would be appropriate. The mannitol, that is gonna be a possible medication treatment, medical treatment, as well as the, sodium chloride solutions. Then, also, some physical interventions that we can do. So if you think about increase in pressure in the head, what kind of position would we want their bed to be in? Right, so that 45 degrees minimum to 90 if they could tolerate it. So it's gonna be a little tricky there to maintain the blood pressure, but we've also got to do everything we can to promote drainage of the cerebrospinal fluid. So specifically in your book, it does talk about raising the head of the bed greater than 45 degrees to facilitate drainage of the venous blood, jugular venous system. Also, keeping the head and the neck in a neutral position, so doing everything that we can to be sure that it is in good alignment with the body and not slumped over this way. So we'd be very cautious with the use of pillows that could cause flexion of the neck. So we want to be sure that we keep that in good alignment, keeping the bed up. And also, The next step that could possibly be necessary too, is gonna talk about is the neurosurgical procedure, like a hemocraniectomy with a urotomy. And that's where I talked about where you actually remove it, the surgeon would remove a section of the skull and the opening of the dura. And that is talked more about on page 874, the surgical management is. And there is a little safety alert there that it mentions, it talks about, the importance of how cautious the client needs to, how the nurse needs to be when moving the client. And then it also talks a little bit more too about some of the medications, barbiturates, phenobarbital, using those to induce a coma, to reduce those metabolic demands on the brain. So even think about some of the things that we did when they had serious lung conditions and they were on a ventilator, and we used things to help sedate them and decrease work of breathing. And so these would be used in order to decrease the stress on the brain, in order to try to allow it to rest and then heal, hopefully, and eliminate the problems that they're having. Or allow them to get to a point where they're stable enough to have some type of neurosurgical procedure or whatever the next steps of their treatment needs to be. And so they're nursing interventions for increased intracranial pressure. And this is a very good acronym to use. And I'm gonna go ahead and show this little, I'm gonna have this video posted for you, but I'm gonna go ahead and show this to you.